Nick Majerison here, welcome to Top Med Talk. And this is the first in a series of podcasts covering EBPOM 2018 and giving you the talks that were given this year at the Institute of Engineering and Technology. We're going to start with this first presentation by Professor Lee Fleisher. Don't forget, more detail on this talk can be found in the Top Med Talk show notes on topmedtalk.com. This talk is entitled Perioperative Brain Health Initiative, a Population Health Safety Initiative. Have a listen.
Top Med Talk.
Professor Lee Fleisher from UPenn in the USA is going to talk to us about the Brain Health Initiative. Lee, thank you very much. Welcome.
It's a real privilege to be here and to speak for the 14th year. I did speak here the first time, so it's wonderful to be back in this venue, and I want to thank Mark, Monty, and Michael and Abstentia for inviting me. I'm going to talk about something that we began about 2 years ago called the Brain Health Initiative. It's something that started with the American Society of Anesthesiologists, and it's actually an attempt to look at the issue of population health. This began as a discussion between our academic society, which at the time I chaired, and the ASA, which is our trade organization, in which we said, everyone talks about how we've done so much for patient safety. The question is, in the US, when was the last time we actually did anything for patient safety? I mean, we actually had questions about that since being lauded by the Institute of Medicine. And the history in this space, and it really began with Dan Cole, who was president then, said that cognitive disorders after surgery we know have been described over 100 years ago, and I'll talk about that in a moment. And for the last 20 years, we've seen a lot of work out of Europe in particular, and now worldwide, about this term of post-operative cognitive dysfunction, or POCD, that it's actually been determined in the elderly. I'm a cardiac complication person, but in the elderly, this is the highest risk complication that we see. We initially suspected it was linked to anesthetics. I'll tell you that most of the data now talks about it being linked to the inflammatory response to surgery, but that can be modified by anesthetics, certainly. There may be a linkage to Alzheimer's disease, the idea that anesthetics do cause amyloid bodies, and there is a lot of questions. We were just funded by our National Institutes of Health to ask if it is linked to the progression of dementia to Alzheimer's. They've had a number of workshops on this worldwide, beginning in 2008, and the last one being in Washington just 3 weeks ago, and I'll talk about the outcome of that. We started this initiative in 2015. It's been silent up until now, or just quietly growing. And what Europe will be actually the first audience to really hear where we're going next. The issue really is twofold. One is delirium, which is much more common. It's much more integrated into other societies. The surgeons are well aware of this, the idea that it affects anywhere from 13 to 50% of patients undergoing non-cardiac surgery, also prevalent in cardiac surgery in the ICU. It costs $164 billion in the US, that it's common, particularly in elderly patients, and that it's frequently preventable. So we've got preventable harm with lots of costs. And this gets the attention of not only most hospital administrators, but also of the U.S. government and of patients, the idea that it's preventable. And the question is, can we reduce the incidence of delirium? If you actually listen to Henrik Kellett, under ERAS, there is no delirium. Now, they send patients home in 1 day. We all know delirium has both an active component, but there's also a silent sort of hypomanic delirium. And many patients, if you ask them once they got home about questions of confusion using the CAM, they may have them at home. And what are we doing to the families and caregivers of these elderly patients as far as the risks without informing them about those risks? I'm actually curious, how many of you here tell your patients who are older that they're at risk for delirium or some cognitive dysfunction after surgery. It's pretty good. That's a lot higher than the United States. We just did a survey, and the answer is probably about 20% in the U.S. We actually have questions about should it be in the consent, and I'll talk about that. So we asked the question, should the public be informed about the risks of surgery and anesthesia on cognition and the vulnerable brain, as we call it, after surgery? How can we get providers really to be galvanized? And the idea really is not just about anesthesiologists or anesthetists, but also the surgeons, the geriatricians, the hospital administrators, the nursing staff. And lastly, when we go to our National Institutes of Health or the MRC here, do they understand that they need to fund this? And actually, you'll hear Miles Berger later today talk about this, and I'll talk about what we're doing in that space. So I want to not read all this. This is not the important thing, but I got this long letter from a patient. Name is Irv. And Irv said two things in this letter that really concerned me. One is he said he experienced several instances of hallucinations, and nursing attributed this to the remnants of anesthesia. Now, we know this is not necessarily the remnants of anesthesia. In fact, Irv hadn't slept for about 50 hours, and that's not an effect necessarily of anesthesia, but they still said that. Hence, he wrote to me as the chair. And then something isn't missed at HUP Anesthesiology with a couple of seniors because he had a friend who had a similar phenomenon. So I'll let you hear from Irv himself. Hopefully this will work.
My wife and a friend were sitting and we were chatting. And suddenly, the room turned on a 45-degree angle. My bed was suspended from the wall. They were sitting down near the floor. The television was on the floor. I knew I was hallucinating.
He knew he was hallucinating, and he worried. And he sent a letter. In fact, he continued hallucinating at home. And his family didn't know what to do, except they knew if they came, they put their hand on him, they actually oriented him, he did better. The second story actually occurred at our meeting 3 weeks ago in Washington. You may recognize another speaker here doing the interviewing. That's Carol Peanin, who is vice chair of the committee that's overseeing the Brain Health Initiative. And the woman on the right, on your right, is Kathy. And in a few weeks, I'll have Kathy's recording, but she said a few interesting things. She said she needed a thyroidectomy. It lasted 4.5 to 5 hours. And she went back to the surgeon after 6 weeks, and she actually described brain fog, and she called it this, which was really interesting. In fact, she said, physically, I felt great, but she was experiencing this brain fog. There's a fog in her brain. I'm a bridge player having trouble. She actually does medical simulation with patients, and she couldn't do it because she couldn't remember the scripts. And in fact, just about 3 days ago, I got text by a friend who said they had a similar surgery just a month ago, a friend of theirs, and they had a complete workup of an MRI and a CT scan for this exact same phenomenon, and nobody could figure it out because nobody thought about delayed post-operative recovery, about neuroinflammation in the brain. And she really said it's better, but it's not clear at 3 months, but at 4 to 5 months, it got better. And when she spoke to her colleagues, particularly her male colleagues, they all denied that they ever experienced it, being the men. The minute that the Washington Post had an article on this brain fog, and I'll show it to you at the end, everyone, once it was validated, all the men came out and said, you know, she's 75. We all had the same thing, or we all felt very similarly. So it was interesting that they couldn't actually legitimize her feelings, but what she wanted was that legitimacy that what she was experiencing did concern her, and that it would get better, most importantly. So she said, I wish that that what I was experiencing was normal. And that's one of the goals we think is important for us to legitimize who we are and where we can take some leadership. This has been going on for a very long time. In the geriatric literature, he's never been the same since his operation is often heard in geriatric practice. In fact, one of the questions really is if you start out where you have mild cognitive impairment, you're just not legitimately saying you've had it, and you have this neuroinflammation, you take a deep dive for a short time, and you come back, but you're already on a slope. The question is, does that slope get worse, or are you just aware that you're getting worse, and that's why they've never been the same, that once they had the stress of surgery, it's made them feel much worse. So one of the things that we actually know is that surgery is occurring at a time when normal aging is happening, that people are developing mild cognitive impairment. They are either developing the phenotype or the genotype or seeing tau being deposited in their brain. So you're superimposing on a very large percentage of the population this issue. And how should we think about it? Sharon Inouye has actually shown, she's a gerontologist, a geriatric specialist in Boston, that if you actually have surgery, that what you can see is those who develop delirium decline much faster. Is it the stress test that we actually know happens in cardiac and many other conditions, or is this the beginning of a decline? If we prevented the delirium, would we actually see improved cognitive function long term? We don't know the answer to that yet. You will see sometime in the next month a new nomenclature that was developed by a group headed by Liz Everett, who is from Australia, in which they've taken this old term of post-operative cognitive dysfunction and they've mapped it into the DSM, the psychiatry sort of nomenclature, mild neurocognitive delay with mild cognitive impairment, baseline, and then post-operative delirium being the early signs, delayed cognitive recovery being sort of the intermediate, and then mild neurocognitive delay with mild cognitive impairment post-operative, and then the question is long-term. So this will hopefully give researchers and others a nomenclature to actually begin discussing what's happening to our patients. And really what people now believe is it's neuroinflammation. It's that surgery causes the inflammatory response to be activated, that between pain, inflammation, sleep disturbances, surgery plus some degree of anesthesia that we're still looking at for sort of the more mild cognitive impairment. If we give a lower depth of anesthesia, we keep them lighter. Particularly, there's a study called STRIDE coming out that will be published shortly from Fritz Sieber at Johns Hopkins, that sort of if you have multiple comorbidities, he's presented this at the IARS, that in fact using a spinal with sort of light anesthetic doesn't make a difference from deep propofol sedation, but if you have minimal comorbidities and just mild cognitive impairment, that actually keeping patients lighter during their spinal for hip fracture, that they actually do better. So there's suggestion that in a subset, you will see a change. The neuroinflammation, the potential neurotoxicity, and this cognitive dysfunction, and is it fixed or modifiable? So the initiative, in the few minutes I have left, really is our leadership in population health, that this is the team, Rod Eckenhoff, Carol, Stacy Diener, and myself, that what we did instead of the usual practice in the U.S., which with the perioperative surgical home, for those familiar with it, the mistake that we made was actually saying the anesthesiologists are in charge, rather than we're all a team. So we brought in a lot of teams. We, in fact, had the American College of Surgeons, the ESA, our VA, the nurse anesthetists, the National Quality Forum, our payers, and our research teams. And we met in Washington, about 80 of us, And we really said that our priorities are, how do we identify patients at risk? Should we start doing screening? How do we encourage providers to actually promote best practices, since there are things called Beers criteria drugs that we could avoid, and we'll talk about that. And how do we educate anesthesiologists regarding these choices? And this is really the work that Carol is doing, giving her QI expertise. That we have resources on a website, and our hope is to shortly link with websites around the world to actually direct patients and providers to each other's resources, from like the American Heart Association, the Hospital Association, even Medicare, our payer. And with respect to identifying, we're trying to get anesthesiologists to add in screening questions. Have you noticed problems remembering things? My daughter would say, I always repeat the same questions or stories again. So maybe I have mild cognitive impairment, but then I've had it since I was about 21. But the issue is, how do we get to that without worrying people, without giving them a diagnosis? Because we're not psychometricians, we're not neuropsychologists. We just want to say we should worry in this person more than others. Should we actually, and there are people developing sort of the infamous clock face, to say your clock face isn't as perfect, that's the patient we should worry about. The American College of Surgeons worked with the American Geriatric Society and the NSQIP group and actually have a whole bunch of recommendations, including the idea of screening, that we should get into the habit. How many people screen with some questions about cognitive function pre-op? Less than people who actually said they had discussions about it. So it's something we really should start doing, and we hope will become routine practice in the US and perhaps worldwide, with just some simple questions. These are some that we put up on the website. Are you taking certain memory drugs? Have you had an episode of confusion? We all talk about MH. Do we talk about delirium after surgery? It would be an excellent question to ask. And remembering, do you have these aids of eyeglasses, hearing aids, that you can bring to the hospital? A lot of people are thinking about music. Can we bring in music that the patient actually grew up with or that loves that would actually help them? In the US, there's something called a show called House Hunters International. It's on at 10:30 p.m. every night. Could we actually program people's TVs in the hospital that they actually have the programs they watch that would orient them to it's time to go to sleep or time to wake up? Could we use different cues to make people more aware? In fact, this is this group, they said there should be a geriatric anesthesiologist in every department. That, in fact, routine care of elderly medical, frailty. You all have geriatric anesthesiologists, or we all are geriatric anesthesiologists? This is the way it was phrased, so we'll get back to Stacy. Yeah, I'm becoming a geriatric anesthesiologist quickly. But this idea of really having someone with expertise in your departments to help design it with our surgeons, with our hospitals. We also have optimal management, daily physical activity, really lots of things you can do to try to early mobilize them, this idea of ERAS being very positive for delirium. We just should inform our patients, and more importantly their caregivers, that this could continue at home, particularly if they don't get sleep. When we tried to describe this to a bunch of 25-year-old design students who were thinking about interventions, we said, think about it. When you probably pulled all-nighters in college, you actually collapsed the next day, you slept for an hour, it's dark out, and you're totally confused. Is it night? Is it the morning before the sun comes up? Or is it the evening when you're going to sleep? That's how these patients feel. What would you design to help them orient themselves? There's Beers criteria, and these are the lists of drugs. There's a paper coming out in Annals of Surgery that I reviewed, where if they have higher anticholinergic pre-op, our patients do worse and have longer lengths of stay post-op. Really interesting data. So can we make sure we're going to have pop-up windows? Because in my hospital, the surgical house officers frequently order Benadryl to help patients sleep at night. Really bad drug to give these elderly patients. So maybe we can help by changing this. We can optimize pain management. We can orient them. We can make sure one of the ideas is to actually record something on an iPad, maybe while patients are waiting for surgery, in which the family member says, "Grandma, you just had surgery. You're in the hospital of the University of Pennsylvania. I'll be by later today. See you soon." And then we're actually building a new hospital that Sir Norman Foster is designing that will have essentially Apple TVs in every room. And could we actually play that back for our patients? You could actually, this is a story that Carol got, and we have lots of them, of ways to actually prepare patients more for what they know. So I'll end with two things that helped. And one was we did a press release that talked about what you should know around surgery and after surgery. This was picked up by the Washington Post and by lots of papers throughout the country. And Rod Eckenhoff, my vice chair, said that we know this does happen, but not to be concerned because it typically goes away. But maybe we should actually give them sort of a puzzle that holds their keys. Grandma's keys are in the puzzle. Until they figure out how to open that without smashing it, they can't drive. So this idea of really preparing them for what's going to happen post-op. So we had these work groups. So our next steps, we're going to have provider communication. We're going to have a stakeholder statement from everyone. We're going to have a playbook that we're going to create. We're going to have websites with links, and we're going to have a chesting channel, our veterans hospitals. We're going to work with patients. We're going to have patient stories, press releases, simple material that we want to hand our patients that hopefully we can work with your college. And we want to talk to our funders because we actually think it's time, if we went to Congress, in Congress, as you know, our country's a little screwed up right now. But, you had Brexit, we have whatever. Or whoever. But it's really 25-year-olds who are running the Congress, and they all have grandparents. And that's who we're going to tell these stories because they all know about them. Thank you again, Monty, for this invitation.
Top Med Talk. And don't forget you can meet the Top Med Talk team. All you need to do is turn up at one of our events. Check out ebpom.org for more details. ebpom.org. Our next big event is between the 28th and the 30th of September in Chicago. That's EBPOM USA, the Chicago Master's Course, Perioperative Care Practicum. Between the 28th and the 30th of September, ebpom.org for more details. That's ebpom.org.